Hello and welcome to 30 Minutes. I'm Rick Anthony. Today's program is a sequel that I did recently with Dr. Frank Speidel. Dr. Speidel is semi-retired, I guess, having topped off a very impressive career. His credentials include an undergraduate degree in physics, an MB from Temple University School of Medicine, an MBA from the Wharton School in Finance and Information Systems. He's currently executive in residence of healthcare at LeBeau College of Business at Drexel University. But more to the point, for purpose of today's visit, which is, as I said, a sequel, a follow-on to a 30-minute show we did not too long ago on the state of healthcare in the United States, is his experience as years spending time in the trenches, quite literally, in the emergency rooms of several large health systems as well as standalone hospitals, as the CEO, as a member of several administrative and governing bodies within the healthcare system. So he's got different vantage points and therefore some pretty sharp perspectives on the cost, the quality, and the trade-offs of cost and quality in healthcare today, what we might expect, what we're getting in return for the enormous amount of money we're spending on healthcare in this country, and the education of the next generation of physicians. These are all topics we didn't get to talk about the first time we were visiting, and so Dr. Speidel, welcome back to 30 Minutes here at Radnor Studio 21. We spent a little time the last time we were together talking about quality and cost. You want to talk about the quality of healthcare and, from your perspective, the strides we've made in improving outcomes?
Thank you for having me again, Rick, and I appreciate the chance to share and start these discussions, which we need to have in a very intense way, I think, to make things better. Quality, we've heard about quality forever. One of the things that I find entertaining is that sometimes we can't agree on what is a good quality measure.
Thank you. I was going to ask, how do you define quality in healthcare? Because quality is not necessarily, hey, we beat the reaper, that person is still alive, but barely. And looking and the outlook is not very good for quality of life.
You are so spot on about that. We can pick a very vague term like it's improving the life experience of people who are suffering, and we can say that's quality, but that's kind of hard to measure, isn't it? And I'm not sure that if we prolong death, that's the same as improving life.
Right.
But some concepts that we do use to measure quality, I always have an entertaining time discussing this with students. Is mortality rates, is that a good measure of quality? I mean, superficially, I would think so. You know, if you go in to have your gallbladder out, you'd want to have it done in a place that has the lowest mortality rate for cholecystectomies. When Bill Clinton had his coronary artery bypass surgery, his open heart surgery, he had it at the institution that had the highest mortality rates for that procedure.
Really?
Sure.
Because was it set up by Republicans?
Yes. No. The reason for that was that they were doing the hardest cases. I can always lower my mortality rate by patient selection. And I've seen this. I've seen this in institutions throughout the country. We're going to market ourselves for having low mortality rates. So if this person has a lot of confounding problems, we're not going to do the surgery. So I can lower my mortality rates. Another thing, bless us and keep us. We need to be patient-centric. And this is one of the great things we've changed. I think we are, in some ways, reinventing ourselves and focusing on the patient. We did that very well a long time ago when I got into medicine.
Yes.
That kind of disappeared with the technology. But now we're emphasizing patients being the center of why we come to work every day. So patient satisfaction is something that we should be focusing on and using that to measure quality. So one of the chapters in the book, I was fortunate one time, I was in charge of an emergency department, and I had a gentleman who moonlit for me. And he was board certified in infectious disease and pediatrics, and he happened to run the pediatric department down at CHOP. So he was an emergency physician and was also an infectious disease person. 1 month he was in the emergency department, the other month he was doing ID rounds down at CHOP. one night he was taking care of a little infant, comes in with a fever. And you know how kids are. They get fevers. They're always catching something. The child is cranky, and mom's stressed out because she's got other children. And he did the right thing. He talked to mom and examined the patient, I'm sure knowing the way Gary did medicine. And he sent her out without antibiotics and explained to her that this was most likely a benign febrile illness that would run its course, and how to take care of a fever and what to look for. Mom did not come to the emergency department to leave without antibiotics. Mm-hmm. Her family doctor who sent her in did not send her in to have a bill created and not get antibiotics. So I had two dissatisfied people there. And that hurt patient satisfaction. And it was good medicine. And what I could tell, Gary did everything right in explaining the care for fevers, but that was not what the patient expected. So sometimes doing good medicine, providing the care that's appropriate, will disappoint a patient. So you have to have a little suspicion about that. And the same thing goes with the problems we have with opiates right now. One of the driving forces in the early 90s was patient satisfaction, when we metriced ourselves. How well do we provide care? Mm-hmm. When I say no to somebody because I'm concerned that they are abusing opiates, that person is not happy. And when they get surveyed, they're going to give us a low grade. So you have to have a little index suspicion about patient satisfaction. I
understand what you just said, and I totally agree with it based on my own experience. Well, I won't go into that, a personal matter. But tell me this. People are encouraged now to shop, right? Shop for health care. Don't be satisfied with just one diagnosis or one estimated cost. Go out and see what else is available. They don't even know what they're shopping for the most part. They're shopping cost because we've been conditioned to think in terms of costs rather than outcomes.
You're so right. It's very hard, like mortality. How do we judge the outcome we want? This is a tough question, and that's something that I don't have an answer for that.
Should people not shop?
Oh, they should shop.
What are they shopping for?
Okay, you can look at costs, but I think first thing I would recommend people do is that they have a relationship with the care providers that they have confidence in. I would be terrified of going to somebody that I couldn't talk to and ask questions. Enlist other people. Who have you gone to that you have felt comfortable with, that they listen to you? I think a lot we would improve if we would just get ourselves back to listening to what the patient is telling us.
Frank, when I was diagnosed with prostate cancer, and I still remember this, I got the call, had the biopsy, had the call, and the doctor called and said the test was positive, Mr. Anthony, we found cancer. And I had to sit down. It was like being hit with a thunderbolt, the C word, cancer. Mm-hmm. And almost the next sentence was, when do you want to schedule surgery? I said, wait a minute. What are you talking about? Well, most of my patients, we take care of it. We just do surgery. But doctor, what are my options? Well, you can do this, you can do that, but my recommendation is that we schedule you for surgery. I'll call you back, doctor. And I spent a year doing research to determine which of the options was probably best for me, given what I understood my condition to be. And I finally ended up with surgery because I was referred by a radiologist to a surgeon, his urologist. His name is Dr. Lee Bergman. I don't hesitate to use his name because I think he saved my life. And Dr. Bergman took a few days, and he called me back, and he said, Mr. Anthony, if you were my father, I would recommend surgery because you're not a candidate for these other options. I trusted him. He took the time. He listened to me.
Yes.
And he came back with a rational argument for the gold standard is surgery. Do it. I don't regret that one bit because I know of other people who did not opt for surgery. They opted for seeds or radiation or whatever, and the cancer came back years later.
And sometimes just having the relationship. One of the things I attack in my book is the concept that a doctor is a doctor is a doctor. Oh no. Physicians are human beings. There are some that are wonderful and celebrate their careers and are out beyond themselves. There are others, unfortunately, who could just be manufacturing widgets.
So what are the medical schools doing these days to produce better physicians who know not only how to hit keys in a laptop or a personal computer, but know enough to look up? I have another one. I have a specialist for every part of my body now. But my cardiologist brings someone into the room, and she sits and she takes notes. He pays attention to me. I have others who, as soon as they walk in the room, it's 9 minutes with the patient, most of the time with the head down, hitting keys for the computer, recording because they're required to do it. Are we pumping, and these were the younger for the most part, are we producing physicians who don't know how to be doctors?
I can't, there's more than 170 med schools in the United States, and I would be an arrogant fool if I tried to comment on how they're educating all their students. We can always do things better. And I can only judge by my own experience like yours. My son was playing football for his college, and he had a significant injury. He was seen and treated at the local hospital. He was then transferred to a quaternary center, a major medical institution, famous. It's hard not to see it. And we spent hours there. I had no problems with that because it was a busy emergency department. He was seen by the trauma service, they cleared him, and then he got referred to orthopedics. Hours later, a physician came in. He was the intern. This was his first year, and this was in September, so he's just been a doctor for a few months. And looked at my son and I and said, well, I checked the imaging studies, I checked the CAT scan and the MRI, you're okay. We're going to send you out of here and you're going to be on crutches. And you're going to get something for pain and follow up with your family doctor. He never talked to my son, he never took his history, never asked the appropriate questions for the mechanism of injury and everything like that. And he never touched him. He never did a physical examination.
That's malpractice, isn't it?
It's not the way you want to practice medicine. I never advertise that I'm a doc. I never advertise I'm a physician. I'm Frank Speidel. So my son's here, so I said, just a second. I said, his pelvis is unstable. And I walked over and I said, look, on anterior and posterior compression and lateral compression, he's got significant symptoms, especially on the lateral compression. And I said, and he can't stand, he can't bear weight. And I wasn't trying to embarrass him, but it was, you know, we got to
basic stuff.
We got to move on from this. And I know you're tired, and maybe you've been up for the last 20 hours. And that's one of the challenges. We got to find a way that we never leave the fundamentals. So, and it turned out my son's X-rays were read incorrectly, but if you did the physical examination and you took the history, there's a problem here. We got to find it.
But what was the reaction of the young doctor? Did he thank you? Did he acquiesce? Did what?
He looked at me and said, "Who are you?" And I said, "I'm Connor's dad, and I've done emergency medicine for about 35 years." And you know, and he went out, and when he came back with his attending, who was wonderful. The attending was the man you want taking care of your child. He asked great history and got a great, and did the physical examination and made it a teaching moment for everybody in the room. And he said, and you tell me the CAT scan and the MRI are negative, we're going to go down and review that. And comes back about 40 minutes later and says, we found the fracture. And that's the way it should go. Yeah. But unfortunately, not everyone's going to have the family.
You know, I neglected to mention in this segment that all of these experiences, your life experience and so on, are all jam-packed in a book called Healthcare in the United States or the U.S., a Dancing Beneath the Diamond Sky.
Yes, sir.
Which is in manuscript form now.
Yes.
And you're looking for a publisher.
I'm going to be looking for an agent.
An agent.
Yeah, somebody who wants to shake up the discussion of healthcare in a new way.
I think you can do it. I think you can do it. You know, we've talked about healthcare within the four walls of a hospital or a health system. Can we segue now to the quality of care after the patient leaves the hospital and is sent home with a bunch of papers like this, with a list of things they're supposed to do and not do, with a lot of stuff they don't understand, with a list of prescriptions they're supposed to take, when they're supposed to take them, and what they're not supposed to take because of interaction with other stuff they're on. The point is, it is a setup for confusion, for anxiety. Are we getting any better in following the patient beyond the four walls of the hospital into their home, those with chronic illnesses?
This is a great, huge, massive challenge. When you leave the structure, and sometimes it's chaotic, but when you leave the structure of an acute care facility and you get returned to the community, it's like a ship sailing out of the harbor in the middle of a hurricane. Things don't get better when you leave the breakwater. Think of this. The people that we're sending out sometimes are very elderly, have little resources in the sense of a lot of caregivers, are sick, are compromised by other comorbid conditions, and there's so much tasking, so many things to be done out there. It seems like a situation that's ripe for some kind of support structure that's information-based.
Mm-hmm.
I think the opportunity to create a platform that kind of brings, there's lots of resources out there, but if you don't know where they're at, if you don't know how to access them, you got a problem. And we've got to find a way to create a platform that will allow people to return to the community, to enjoy a better quality of life. You never want to be in a hospital. To be out in your community, in your familiar surroundings, but also have support that you're not at sea in the hurricane.
And the problem, to the extent that it is a problem, is exacerbated by the fact that more and more older adults prefer to age in place.
Yes.
They don't want to leave their homes.
Yes.
But I'm sure you're familiar with Beacon Hill.
Yes.
What is that, 20 years ago?
Mm-hmm.
When a group of people who lived in that section of Boston decided they were not going to go into senior living facilities. Instead, they would create an informal coalition of some type and bring the services into the community. That was the beginning, I think. And I understand there are now well over 100 of them established around the country and another 100 that are in various forms of formation. It seems to be at least one small answer.
These initiatives
People become responsible for themselves,
and these initiatives can all be amplified too.
Mm-hmm.
If we put a platform structure there that takes the machine and uses it to provide the resources for people who need help, we're doing the right thing.
Mm-hmm.
It's a new frontier.
But just as we were talking about education for physicians, so that they can practice medicine in today's environment, I think there's a similar need for caregivers. There are little resources for caregivers. There's a statistic that I'm familiar with because of some work we're doing, that there are 45 million caregivers in this country today. 15 million of them are employed. They're holding down jobs. And the stress, the anxiety, the depression, talk about opiates and whatnot, drug abuse as a result of trying to handle a job and do well there and take care of a mother, father, other family member at home. It compounded, the number of caregivers is going up while the need for caregiving is going up. What's the solution to all of that? Is it technology?
Hopefully it will be. Hopefully we'll find ways to mobilize resources that people need a break from being a caregiver.
Yeah.
And that's out there. We've got to get it out there in an affordable way, and people have to know about and have to be able to access it.
Will we see robotic caregivers in our time?
Wow. I hadn't thought about that. That's a great question.
I know there's work being done, and I've seen some prototypes of ugly-looking machines that can dispense medication.
To the extent that we have something like Alexa that can, interface on spoken commands, we're seeing that now.
But you know the argument, to the extent that we're able to push that technology into the home, there's the privacy issue.
Sure.
Alexa is listening.
Yes, it's always listening. Now, the other thing, too, is that there's a certain sterility, no matter how we change it. We don't like to interact with machines too much, do we? I'd much rather see my niece than I would...
There's no question about that, but I did read a study recently where older people who are isolated, don't have caregivers, don't have other family members, they really become attached to the machine, to Alexa, which is not a healthy thing, because they're treating that interaction as almost human-like, and beginning to delude themselves. And anyway, it's quite a challenge.
Challenge and an opportunity.
And an opportunity. Yep. I asked you before in the first segment whether or not, in view of all the stuff that's going on, you're optimistic about the future of healthcare. You said absolutely, and you went on and soared with all of the opportunity. Let me ask you the same question. In view of cost, limited resources, the politics that gets involved in all of this stuff, the fact that we have a society that is virtually illiterate when it comes to their own health and how to take care of themselves. We have opportunists who are selling supplements and potions and exercise routines, all in the hope and expectation of either preventing or fixing the problems. So we have all of that chicanery going on. You're still optimistic that in the final analysis we'll be doing a better job 10, 15, 20 years from now of taking care of ourselves and others who are responsible for our care? That's a long-winded question, but there it is.
And I still remain optimistic, Rick, and I hear everything you're saying. The best prediction of future performance is past performance. And I have seen us fly through the misery of not having any options for treating people with hepatitis C or HIV, and seen us soar and achieve things. And I've seen us return to focusing on the patient. I've seen us return. Look, let me just go back and talk about quality for a second. You know, at one time when I grew up in medicine, quality was kind of the I gotcha game, where somebody messes up, we're going to punish the individual. We've come so far from that. I have seen quality in medicine look at individuals are human and they make mistakes. We got to fix the system. We look for system solutions. We look for system improvements. That when people are human, when they are tired or when they're agitated or distracted, that things don't go right, that there is a system placed around to prevent it or to correct it and identify it right away. This is a huge change I've seen in my career, where we've had a much more healthy approach to quality. Now, it comes with a cost. One of the great things that people tend to say is, well, if we improve quality, it's going to lower the cost of medicine.
Right.
It doesn't. Running a hospital, you won't worry about things like falls. A patient gets their gallbladder out, they're medicated, they get up, they fall, and they break their hip. That's bad medicine. We don't want that to happen. Now, one way to prevent that is to increase the nursing staff, but that pushes my costs up.
Right.
So falls are down, staffing's up. Improving quality. If I improve quality, I expect people will live longer.
Yes.
Think about that. When we live longer, do we consume more health care or less health care?
Yes.
We consume more health care. Back in the dark days before we had insulin, type 1 diabetics died. They didn't go on like we do now. Now we treat their diabetes. The type 1 diabetic gets treated with insulin and wonderful insulin therapies, smart pumps, da-da-da-da-da. But they still have problems. They're still going to have more heart disease. They're going to have more kidney disease. They're going to consume more health care. But it's an improved quality of medicine.
But there are instances where there is a direct correlation, I think. I know you'd agree with this. One comes quickly to mind. Between better quality of care, better delivery of the care, and reduction in cost. For example, as you know much better than I, under the regs now, if a patient leaves the hospital and is returned within 30 days with the same illness, the hospital gets slapped on average $15,000, or is readmitted is admitted to the ER. It's another $10,000. So there's an economic incentive for hospitals, healthcare providers, to keep people out of the hospital.
Yes.
Under certain circumstances.
Even beyond it's the right thing to do.
Doesn't that put the individual in some jeopardy? That the hospital will be driven by a cost consideration rather than the welfare of the patient?
I couldn't agree with you more. I think that it's one of the challenges is to act in a fiscally responsible way,
right,
to provide the care in an effective way. But the danger is that you become too passionate, right, and that you harm people trying to control.
In your
cost.
opinion, and based on your experience, are for-profit health systems better at delivering quality care than not-for-profits?
I honestly have not seen. I've been in for-profit and profit.
Yeah.
I've been in faith-based and non-faith affiliated institutions, and I haven't noticed anyone per se doing quality better. To my surprise, and I shared this with you before, one of the most ethical and patient-motivated institutions that I worked with was a for-profit. They were absolutely adamant. Do what's right for the patient all the time, every time. We'll take care of the finance. We'll take care of any legal considerations. So I have to say that I certainly can endorse one for-profit institution.
You said in the first segment, and again earlier in this one, that your hope for the book, your intention, the purpose of the book, is to generate debate, conversation, right?
Yes. And
to challenge some of the maybe myths, beliefs, consensus that we have been working with for so long. You're one person. Are there others like you who represent a movement in that direction?
I'm not that bright.
Get it all out on the table?
I've stolen these ideas from other people. It's the people that I've...
Are there others talking about it, though? Is there a groundswell?
I don't know if there's a groundswell, but I have seen people that are challenging the conventional beliefs about things. The idea of quality. There's a Brit psychologist, James Reason, who got involved with error and understood that the prevention of error was a system solution and not wrapping people in the knuckles. There's a lot of original talking going on out there.
Well, it's been fascinating. Again, thank you very much. Again, Dr. Frank Speidel, an impressive career with a book that he's working on, the title of which is Healthcare in the U.S., Dancing Beneath the Diamond Sky. And you said you stole that line as well, right?
Yes, I did.
From?
Bob Dylan.
Bob Dylan, of course.
Nobel laureate in literature.
Okay. Thank you again for being here.
Thanks, Rick. Have a great day.
Well, we'll have you back again as we see more headlines about great successes. My guest today has been Dr. Frank Speidel. Fascinating subject. Until next time, this is 30 Minutes. I am Rick Anthony. Take very good care of yourselves.